My name is Jeff Resnick. I'm Chief of the History of Medicine Division here at the National Library of Medicine of the National Institutes of Health. I'd like to thank you all for joining us today here at the Natcher Conference Center at NIH, and to those of you who are watching remotely. We're here to hear the first lecture in the National Library of Medicine's 2018 History of Medicine Lecture Series. The series promotes awareness and use of NLM and other historical collections for research, education, and public service in biomedicine, the social sciences, and the humanities. The series also supports the commitment of the NLM to recognize the diversity of its collections, which span 10 centuries, encompass a wide range of formats, digital and physical, and originate from nearly every part of the globe. And also, of course, to appreciate the individuals of the various disciplines who value these collections and use them to advance their research, teaching, and learning. All of our lectures are free, open to the public, and are live streamed globally and subsequently archived by NIH Videocasting, thanks to a generous gift from the Michael E. DeBakey Medical Foundation to the National Library of Medicine. Any first lecture in an annual series is an event. This one is particularly special because it's the keynote presentation of Viral Networks, an advanced workshop in digital humanities and medical history. The partnership behind this workshop between the National Library of Medicine and the National Endowment for the Humanities is now 6 years old. Since it began, our agencies have worked together with several like-minded institutions, particularly Virginia Tech, as well as the Wellcome Trust and the Maryland Institute for Technology and the Humanities, to bring together individuals of multiple disciplines to think together about data and new digital tools which can advance research intersecting with the history of medicine, the digital humanities, and the biomedical sciences. The noted researchers Erez Aden and Jean-Baptiste Michel discussed this partnership between the NLM and the NEH in their 2013 book entitled Uncharted: Big Data as a Lens on Human Culture. In doing so, they described as, quote, dead on, the very name of the first program to emerge from the NLM-NEH collaboration through a grant from the NEH to the Maryland Institute for Technology and the Humanities. That program was the 2013 conference entitled Shared Horizons: Data, Biomedicine, and the Digital Humanities. That conference, Shared Horizons, and the collaboration behind it, Aden and Michel explained, quote, pointed to the most exciting terrain in our intellectual future, being at the interface of all our work, end quote. They continued, no one quite knows what to call it, and no one knows quite where it's going. But one thing is certain, they explained. Science and the humanities are becoming, once again, kindred spirits. Just as Galileo transformed our understanding of the world in the 17th century, these two lenses, science and the humanities, back to back, will do the same in the 21st. Today's keynote address by Dr. Theresa MacPhail and the associated Viral Networks workshop are of a piece with this exciting research trajectory that are appreciated by Aden and Michel and many of you here in the room, of course, and out there in the world. And it's supported so boldly by the NEH and the National Library of Medicine. Before I introduce Dr. MacPhail, I want to welcome and introduce the leaders of the National Library of Medicine and the National Endowment for the Humanities, and certainly thank them for their valuable time and their support in paving new research pathways which intersect the history of medicine, the digital humanities, and the biomedical sciences. Dr. Patricia Flatley Brennan is director of the National Library of Medicine. Dr. Brennan came to the NIH from the University of Wisconsin-Madison, where she was the Lillian L. Molman Bascom Professor at the School of Nursing and College of Engineering. She also led the Living Environments Laboratory at the Wisconsin Institutes for Discovery, which develops new ways for effective visualization of high-dimensional data. Dr. Brennan is a pioneer in the development of information systems for patients. She developed ComputerLink, an electronic network designed to reduce isolation and improve self-care among home patients. She also directed HealthCare, a web-based information and communication service that helps home-dwelling cardiac patients recover faster and with fewer symptoms. She also directed Project Health Design, an initiative designed to stimulate the next generation of personal health records. Dr. Brennan has conducted external evaluations of health information technology architectures and worked to repurpose engineering methods for healthcare. A past president of the American Medical Informatics Association, Dr. Brennan was, in 2001, elected to the Institute of Medicine of the National Academy of Sciences, now, of course, the National Academy of Medicine. She is a fellow of the American Academy of Nursing, the American College of Medical Informatics, and the New York Academy of Medicine. John Parrish Peattie is Senior Deputy Chairman of the National Endowment for the Humanities. Previously, he served as publisher of the Virginia Quarterly Review at the University of Virginia, a Literature Grants Director at the National Endowment for the Arts, Counselor to the National Endowment for the Arts Chairman Dana Gioia, and Director of the NEA Operation Homecoming, writing the Wartime Experience Program at the NEA. Mr. Peattie served as Director of the NEA Big Read Program, Director of Communications at Millsaps College, as well as founding editor of Millsaps Magazine, as well as editor at Mercer University Press, with a focus, of course, on the humanities. An accomplished writer and editor, he has composed speeches for a U.S. President, a First Lady, and a Librarian of Congress. Please join me first in welcoming Dr. Brennan, who will offer her remarks, and then Mr. Peattie. Thank you.
Good morning and welcome, those who are in the room, those who are listening live, and those who are listening in the future. I am happy to bring greetings to you as the director of the National Library of Medicine, one of the most amazingly wonderful things I get to say very often. I actually, though, am particularly excited about this workshop and all of our work with the History of Medicine Division. While my work in computer outreach for patient care started 30 years ago, 35 years ago, I first learned about the connection between creative writing and the humanities through a program at Hiram College in Cleveland. And I've recognized through time that humanities have much to offer us as we bring a scientific and engineering approach to thinking about that which can only be experienced by humans. Today, I'm particularly pleased to be welcoming you to the first of our lecture series for the 2018 History of Medicine lecture series, and also to the keynote presentation, Viral Networks, an advanced workshop in the digital humanities and medical history. You've got a big day ahead of you. The National Library is proud to be co-hosting this workshop here and joint with the National Endowment for the Humanities, who provided the grant that's made it possible. This program is bringing together a number of selected scholars from various fields of medical history and anthropology, as we know, who are pushing the envelopes at the intersection of medical history and the digital humanities during the time of ever-expanding digital resources and data-driven research, both in the humanities and the biomedical sciences. Our own work at Wisconsin emphasized quite a bit of the visualization of text in 3D or immersive visualization tools to allow, for example, the tracing of plots through movies. Now, though, this workshop today is a workshop on networks, how appropriate, connecting new computational tools for analyzing large-scale interactions among people, organizations, and ideas with the established humanities scholarship, which I just love this, on training, value, and the significance over time and across cultures. Interpretation is rich and is richly aided by the tools that you are building here. I bring a warm welcome to our scholars who are participating in the work, and also to Dr. Theresa MacPhail, who will be delivering the keynote address. I am encouraging all of you much success as you think beyond your disciplinary boundaries to exchange and to preserve and to pursue research ideas that will bring forward some methods that can be used broadly around the world and contribute your chapters to the planned open access scholarly publication. Again, I'd like to express my gratitude directly to the National Endowment for the Humanities for their support through this initiative to a grant through Virginia Tech. I thank our colleagues at Virginia Tech for a long collaboration, and in the History of Medicine Division for working together, not only to make this particular program a reality, but also to make it another in a series of a 6-year relationship in the NLM-NEH partnership, made possible through a memorandum of understanding. Where earlier, Jeff mentioned one of the programs, the Shared Horizons, but there are others in our past, at Epidemiology of Information, New Methods for Interpreting Disease and Data from 2013, and the 2016 workshop on Images and Text in Medical History. We have a long and productive relationship, and Chairman Peattie and I have reaffirmed this understanding by co-signing a new memorandum of understanding that will enhance our partnerships through 2021. These partnerships are quite important to the National Library of Medicine because they help create and sustain an interdisciplinary and collaborative platform for discovery at the National Library and across the NLM campus. Creating such a platform is a key goal of our new strategic plan and our commitment to a growing data infrastructure and supporting data-driven scholarship and inquiry for the benefit of medical research, as well as the disciplines that intersect with medical research, like the humanities and the medical humanities. As we all know, the quantitative and qualitative data abounds in at the very history of medicine, the vast recorded experiences of health and disease It's coming faster, it's coming at an increasing speed, and for the benefit of current and future scholarships across the discipline, activities such as this workshop today are essential to help envision research tools, envision questions, and to find new ways to ask and answer these questions. Once again, I welcome all of you. I wish you a successful workshop and an enjoyable time with our keynote speaker, Dr. MacPhail, and I now turn the podium to Mr. Petey. Thank you.
Good morning. Thank you, Dr. Brennan. This has been an absolute pleasure. The tour of NLM this morning was clearly made clear how remarkable an institution it is, and I also want to say that that's reflected in the staff, too. I know from my previous tour in the federal government, I, for about 7 years, taught writing workshops at hospitals in Afghanistan, Walter Reed, military bases, and when I wanted to think therapeutically what our troops are going through, I could turn to Jeff Resnick's book on World War I British hospitals, and there was a lot of continuity across time. And I know another colleague from grad school days, John Reese, works here, and it's been about a quarter of a century, but since we've worked together, but I know of his excellence. So I just want to say what a pleasure it is to be here. Also, I want to acknowledge my NEH colleagues, if they might raise their hands so people in the room will see them, and I hope you have a chance to speak with them. Particularly glad to have our Director of Digital Humanities here, Brett Bobley, who's been a great advisor to me on the importance of this relationship. And I'm particularly pleased to see the important research coming out of this NEH-funded Viral Networks workshop, and with the wealth of historical resources about the development of modern medicine. And if you'll allow me a moment, I want to say a personal aside about the importance of medicine as a subject to me. My late father was a surgeon and a general practitioner, and my mother was director of medical records at a small Mississippi hospital where I was born. They came there for Dr. Hardy's team that ultimately did the first heart transplant in this world, and of course later did the first heart lung transplant. And around age 7 or 8, I learned about the birds and the bees from a purloined reading from a massive gross anatomy textbook. I remember the bright blue cover, and I remember very horrifying black and white photographs. I still believe it is the finest abstinence textbook ever created. And in high school, I interned at the same hospital. I scrubbed bits of flesh from the instruments before I put them in the autoclave. In college came work study in the nephrology lab, a summer in the embalming room at my uncle's funeral home in another state. And when my father died at 58 with a medical chart in his hand with a patient there, his body was brought back to that hospital where I was born, where my mother was working, and that's where I got the call about his death. And he left behind probably about 15,000 medical files for a town that probably had then maybe 10,000 people. And again, the idea that every single person for a generation and a half, he had a record on them. And you think about this, you look at, if you were to go through that, that is a definitive history of a place in time. How logging injuries shifted to concrete factory injuries, which shifted to injuries of teenagers on the newly created three-wheelers. And you multiply this upon all the towns and the cities across this country, and you think about the untapped historical record hiding in plain sight. So as I've said, medicine is dear to me, and it's a gift to be here with you and to hear a bit about your research and the promises for the future. Now, as you know, the history of medicine is also of great importance to the National Endowment for the Humanities. It's a discipline that touches the lives of everyone, past and present, and it bridges the humanities and the sciences. Public health fields such as epidemiology, biostatistics, health policy, health education, they all rely on the careful study of the history of medicine and disease. whether discussing the pandemic of 1918 or the Ebola outbreak of 2014, historians of medicine play a critical role in determining how we approach disease and treatment. NEH has funded research in the history of medicine since our founding in 1965. Our grants have supported, for example, archival research on the social context of the emergence of HIV/AIDS as a virus, a project that plumbs the near-extinct Central American languages for cultural knowledge about medicinal plants, an educational game about Edward Jenner and the eradication of smallpox, and the digitization of the archives of Albert Sabin. These projects show not only the profound ways the medical sciences have shaped our history and our culture, but also how much rigorous humanities research has to contribute to our understanding of sickness and health. Today, NEH is pleased to team up with the National Library of Medicine, the largest medical library in the world, to renew a cooperative agreement to bring together scholars, scientists, librarians, doctors, and cultural heritage professionals that will join forces on research and programs relevant to our mutual communities. NEH and NLM began our cooperation in 2012 with a Memorandum of Understanding, and as alluded to, we are honored to extend that through 2021 to help support additional conferences and workshops aimed at training historians of medicine on the latest research techniques and to bring together biomedical sciences and humanists to explore possibilities of a collaborative nature. So Dr. Brennan, colleagues, we look forward to many more future and fruitful ventures, such as this week's workshop. And we hope that they will push both the boundaries of the humanities and the biosciences together. Thank you.
Thanks very much to Mr. Peedy and Dr. Brennan both tremendously for your time and your support of this endeavor and all of your respective staffs working together for the purposes that you described so well. It's a privilege to work with our colleagues at the National Endowment for the Humanities, and we look forward to continue doing so. It's my distinct pleasure and privilege to introduce our keynote speaker for this afternoon, Dr. Theresa MacPhail, who is Assistant Professor in the College of Arts and Letters at Stevens Institute of Technology, where she teaches classes in science and technology studies, medical anthropology, and global health. She is also director of the Science and Technology Studies program at Stevens and coordinator of the Medical Humanities minor. Dr. MacPhail is a medical anthropologist with a PhD from UC Berkeley and UCSF, and she has a journalism degree from the University of New Hampshire. In December 2014, Cornell University Press published her first academic book entitled The Viral Network, a pathography of the H1N1 pandemic. The book examines our collective fascination with and fear of viruses through the lens of the 2009 H1N1 pandemic. The Viral Network affords a rare look inside the U.S. Centers for Disease Control as well as Hong Kong's virology labs and Center for Health Protection during a pandemic. Dr. MacPhail looks at the day-to-day practices of virologists and epidemiologists to ask questions about the production of scientific knowledge, the construction of expertise, disease narratives, and the different cultures of public health in the United States, Europe, Hong Kong, and China. Dr. Timothy Choi, director of the Center for Science and Technology at UC Davis, described Dr. MacPhail's book as, quote, insightful, ambitious, and an innovative work which enacts a number of novel ways of conceiving and doing anthropology as pathography, as viral ethnography, and as anthropology of information. Dr. MacPhail's observations, he continued, are sharp, and her data and descriptions are incredibly valuable and offer insight into the inner workings of global public health. Please join me in welcoming Dr. MacPhail here to the National Institutes of Health and thanking her for her lecture today, which is entitled The Evolution of Viral Networks, H1N1, Ebola, and Zika.
Thank you so much for inviting me. I am very excited to be here to update some of the arguments that are in my book on the 2009 H1N1 pandemic. I got a chance to dive into the Ebola and Zika responses, talk to some of my old friends working in global health about those responses. So thank you to everyone who was responsible for this workshop and for inviting me. It's great, so let me just dive in. So when I first began studying the cultural aspects of the prevention, treatment, and study of infectious diseases, I had no idea that I would end up doing my doctoral research inside one of the premier scientific institutions in the world, the United States Centers for Disease Control. In 2003, I moved to Hong Kong right after SARS. In 2005, I was still living in the city when an outbreak of H5N1, or bird flu, occurred. The government's response was swift and unforgiving. Hundreds of thousands of chickens were culled. Fresh markets, like the one shown here, which sold live animals, were temporarily shuttered and then eventually banned in the city. And strict regulations were set up for chicken and duck farms throughout the new territories and on the mainland. The global health community applauded Hong Kong's response, and a year later, in 2006, Margaret Chan was elected as the Director General of the World Health Organization. That's when it occurred to me that outbreaks are about more than just biology and epidemiology. Our responses to outbreaks are conditioned by what we know about past outbreaks. They rely upon institutions and structures put in place as a result of prior outbreaks and are often as much about politics and economic constraints as they are about science. SARS was a dramatic event in China and colored the public health response to everything that followed it. The global public health community's fear of another massive killer pandemic along the lines of the influenza pandemic of 1918, which is, of course, exactly 100 years ago today, was revived by the events in Hong Kong in 2003 and 2005, spurring a decade of pandemic planning. SARS and bird flu also helped to strengthen and expand pathogen surveillance networks that included labs and public health agencies and universities around the globe. SARS had proven that we needed a more robust international response system. The virus had spread rapidly and affected people in over 20 countries before it was over. What bird flu proved was that we needed a more robust surveillance system. The global community couldn't afford to be taken by surprise if another highly infectious pathogen were to emerge. By 2009, when a novel H1N1 influenza strain emerged in rural Mexico, the global health system was ready to come online, so to speak. And here's where the concept of viral network comes in. As I conceive it, a viral network is any group of people, institutions, technologies, and other living and non-living things, like viruses, that are interconnected in order to produce information or knowledge. A viral network exists to create, revise, and transmit information, to get everyone on the same page. That's it. That's its whole function. And yet that function is critical to us being able to act. Action depends on the right information, on what many of us in everyday conversation would call good information. And good information is a patchwork of pieces of data methodically collected by those in the network. The viral network is a superorganism that relies upon its individual parts and yet is able to transcend them. The nodes in that network are hubs of information like the US CDC and the Hong Kong Center for Health Protection, and Mill Hill Laboratories in the UK and the Pasteur Institute in France. Today I'm going to be talking about the health of that viral network and how it may have evolved since 2009. Specifically, I'm going to compare what I know about the events of 2009 during the H1N1 pandemic to what happened during the 2014 and 15 Ebola outbreak in West Africa and the 2015 outbreak of Zika in Brazil, and its rapid spread throughout Latin, Central, and eventually North Americas. I'll be focusing on three things. Lab work, there's an echo. Is that good? Okay. So I'll be focusing on three things. Lab work and its production of biological information about those viruses, surveillance systems and how well they function to alert the global community and initiate the response, and information sharing and coordination systems. or how well we actually perform during these outbreaks, one of which, Zika, will be ongoing for the indefinite future. One of the main arguments in my book is that we have to think about outbreaks, epidemics, and pandemics holistically, that we have to look at everything, at history, politics, economics, biology, culture, all at once in order to understand not only what happened, but what is happening and what is likely to happen in the future. In that vein, I suggested using a medical concept, pathography, or the narrative of an illness, to examine and analyze all the events that make up what we eventually simply call the 2015 Ebola outbreak. Clearly, influenza, Ebola, and Zika are very different viruses that occasion very different public health responses. But I would argue that they're similar enough, since they all dealt with large-scale events, to make some interesting comparisons and observations. If what happened in 2009 was a test of the global health response system, and some have argued that it was, then what happened in 2014 and 2015 with Ebola and Zika are follow-up exams. We learned some lessons in 2009, which I'm about to start laying out in a minute, and when I agreed to give this talk, what I wanted to investigate for myself was whether or not the lessons we learned had produced any changes in the viral network itself. Had the virus that is global health adapted, mutated, or evolved to be better able to respond to large-scale, highly transmissible infectious diseases? And had those mutations and adaptations produced a more viable superorganism or not? Lest we forget, evolution isn't about progress, and changes can be better or worse for the organism. So with that, let's dive into the recent evolution of the viral network that is global health. I'm going to start with labs. I wasn't sure whether or not to begin with the good news or to save the best for last. But really, I have to begin with lab science and the viral network that produces it. Not only is lab work critical to the functioning of disease surveillance and effective response to outbreaks, it forms the core of the entire superorganism that is global health. And I don't think I'm exaggerating when I argue this. If I really want to convince you that human culture mimics virus cultures, then the laboratory is the best place to begin. The lab is where I really began to understand not only viruses and how they function, but how virologists who work on them communicate and laterally swap information, just like viruses do in host cells. Let me begin with H1N1 as my first example, and then I'll talk about how things may have changed. In 2009, when I was working inside the Global Disease Detection Unit at the CDC in Atlanta, lab reports were everywhere. They were valuable currency in a pandemic gift economy. If you had possession or access to quality lab data, then you had something to trade for other information you didn't have or something to swap. When the epidemiologist I was working with heard about a new outbreak somewhere, the first thing they wanted to see was information on the virus samples collected from patients. Why? Several reasons. The first was to confirm that the pathogen was indeed H1N1 and not something else like generic flu. The second was to track the genetic mutations of the virus to see if it might be adapting to retrovirals or evolving into a more transmissible or deadly version of itself. And finally, in order to design a more effective vaccine, you need quality lab data. When I went to Hong Kong in the spring of 2010, during the so-called second wave of the pandemic, it was nearing its end, and I spent some time observing a flu surveillance lab at the University of Hong Kong. Hong Kong is a node, and arguably one of the most important nodes in the viral network, not only because of the quality of its labs, but because of its proximity to the many novel viruses that seem to come out of Southeast Asia, a hotbed for viral mutations. I also interviewed virologists involved in the initial genetic sequencing of the H1N1 virus. By all accounts, the sequencing of the virus in 2009 was a watershed event. It was, to date, the fastest, most transparent production of phylogenetic information on any new virus that has ever taken place. Laboratories around the globe work together pretty seamlessly to produce quality information. This is the viral network at its best. The lab network is built upon continuous flu surveillance, so it was ready for H1N1. It was already a robust network and easily adapted to the pace of developing events, able to shift gears to focus efforts on understanding this new virus, comparing it to other strains, and producing a vaccine quickly. So let's see how this network functioned during Ebola and Zika. When I began researching for this talk, I expected that labs and virologists would remain the most adaptable segment of the entire system that is global health. And for the most part, that proved true. Of course, rich nations fare better than most, and key nodes in the pathogen surveillance networks are largely located in major global cities. Lab capacity is always a problem during any outbreak of infectious disease, no matter where you are. Because of this, strengthening lab capacity has been a key focus of pandemic planning. By 2014, about 53% of US health jurisdictions had sufficient lab testing capacity. And that's up from just 12% right after 9/11. So that's a significant increase. In 2014, that same year, 44% of US health jurisdictions had surveillance systems in place. Not great, and those numbers haven't increased that much. So let's talk about Ebola first. During the 2014 Ebola outbreak, the lab network functioned fairly well. And I say fairly well for a variety of reasons. First, obviously the Ebola outbreak didn't happen in a place like Hong Kong. And not unlike the emergence of H1N1 in rural Mexico, what ended up being a novel strain of Ebola emerged in rural Guinea. It quickly spread to neighboring Sierra Leone and Liberia. We know that the virus probably emerged in late 2013, but the first case wasn't diagnosed until May 25th, 2014, at the Sentinel lab in Kinshasa. When the lab sounded the alarm in May, it was heated. But here is the big problem. The global viral network missed the first signal that there was a problem developing in West Africa. Because the first cases happened in impoverished rural areas, they went unnoticed. There was a probable case of Ebola in Sierra Leone reported to the WHO by mid-March, and they didn't investigate it. Let me just stop here to speculate about why the first case was ignored. I sat in on many meetings during my time working at the CDC and observed top experts analyzing reports in order to decide which ones needed follow-up or intervention and which ones did not. The first case of Ebola was likely deemed a low priority for intervention because sporadic cases of Ebola are normal for certain locations. And the case hadn't been confirmed yet by a lab within the network, and this is important. There would have been nothing at that point to trigger a response. But that's the real issue here. The viral network doesn't reach everywhere. Clearly, there are many gaps in our surveillance and lab capabilities. That's the first problem. The second problem is that there are so many infectious diseases that present with the exact same symptoms in West Africa that lab testing was critical to the early and rapid diagnosis of Ebola. But the so-called gold standard for confirming Ebola is QRT-PCR-based molecular assays. And here you quickly see a problem. Those assays require equipment and trained personnel. During the outbreak, samples were being transported to central labs. Here's one of those delivery vehicles up on the screen. And that costed a lot of time. So rapid testing was not available. This gap, sometimes diagnosis took as long as 5 days, meant that many initial cases were misdiagnosed or patients were referred to other clinics, which clearly contributed to the spread of disease. The lab in Sierra Leone was quickly overwhelmed with samples, and results were delayed. The use of rapid diagnostic tests, or RDTs, which are cheaper and faster, about 15 minutes to diagnosis, would have been more reasonable. The RDT is less accurate, but the loss of accuracy is more than made up for by the amount of time you save. The international team of virologists that sequenced and tracked the evolution of the virus throughout the outbreak were key to understanding why the virus seemed more mild, and to finding its probable origin. They continued to be key to the development of the various vaccines that are currently in testing. In this way, the viral network is crucial and effective, but it has gaps in coverage that will continue to mean that we are exposed to novel, undetected strains for too long. Ebola was able to get a foothold in West Africa because the Sentinel system failed, and that's largely because the viral network of laboratory science failed. So moving on, what about Zika? This is a curious case, to be sure. Zika is not, as I'm sure some of you already know, new. Scientists first discovered Zika back in 1947 in Uganda. They worked out that it was transmitted via mosquitoes by 1948, and they had found the first human cases by 1952. So from the 1960s up until the 1980s, we see consistent evidence of infections and exposures to Zika in African nations via blood screenings. But Zika is classified as a mild infection, so it stays off the viral network's radar. Then in 2007, the first large outbreak of humans is recorded in Micronesia. Again, the illness is simply mild. In 2012, scientists working to sequence the circulating strain discover that it's different from the African strain, this new Asian strain. The lab network is still clearly functioning throughout this time, as we can see. So the success of lab science does nothing to prevent what happens next. We all know about the novel Asian strain of Zika well before the events in Brazil in March 2015. Lab science has been key not only to tracking Zika's rapid spread, but to confirming cases and testing mothers and fetuses in utero. The viral network also functioned well in our attempts to understand the virus and its connections to microcephaly. There are now 40 vaccine candidates and under development currently. So in many ways, this is a success story, at least on the lab side, but clearly it's not a happy outcome. So what are the lessons? How has the lab network evolved? We're continuously strengthening our lab capacity, and the viral network is continuously adapting and evolving in response to each outbreak. That being said, lab capacity is growing, but not enough. Our reliance on high tech is also hamstringing our ability to do rapid and more pervasive testing. The lab network relies on sampling, but that coverage is limited. That being said, the superorganism that sequences these viruses, tracks their evolutionary changes, works to understand their function, and produce new knowledge about our old enemies is robust. We can quickly produce biological information about pathogens causing outbreaks. What worries me is our capacity to effectively survey for those that are not yet infecting humans or those that are not seen as a threat, such as Zika. The lab network is constrained by limited capacity, limited reach, and limited focus. That focus, however, or what it sees, is constrained by the larger superorganism of global health. So let's go there next. How well are surveillance systems working? There's clearly an overlap between the lab network and their surveillance network. So some of this information is going to sound like I'm repeating myself, and in some ways I am, but I think some of this bears repeating. The viral network is not evolving well in terms of its capacity to predict or prevent widespread outbreaks. The problem may lie in its constant internal mutations, by which I mean that the global surveillance network is constantly shifting its priorities due to political and economic constraints and events. In 2009, the network was heavily focused on bird flu and SARS. So in many ways, it was well equipped to deal with a novel influenza strain. But in 2017, or now in 2018, what were its priorities? What are its priorities? If surveillance systems need human analysts, and they do, then what will those analysts be looking for, and what will they give priority to? Right now, my guess is that the events of 2014 up until 2016, including the recent presidential shift here in the US, have refocused surveillance. Surveillance is, for better or for worse, like an immune system that needs booster shots or reinfection in order to respond well. In this way, the viral network of surveillance is governed by recent diseases du jour, the latest disease. So Ebola, dengue, Zika, and now flu again, with this winter's nasty H1N1 strain causing havoc here in the northern hemisphere. It's the worst flu season on record for a while. The system is reactive rather than active, but this isn't the fault of the system. It's the fault of the analysts. And really, it's not even their fault. Public health in all its forms is constantly focused on its past. It tries to learn from its history, but in doing so, it often repeats the same mistakes. The global disease detection and surveillance system is supposed to be all-seeing. In effect, it is myopic and heavily past-dependent. Let's do a comparison of all three outbreaks, flu, Ebola, and Zika. In each case, we never saw it coming. Or rather, we saw it, but didn't take note of it. In each instance, the sophisticated algorithms we've built to scan various news, blogs, and social media posts in over 46 languages worked. The secondary reporting system that culls information from local medical practitioners, clinics, sentinel hospitals, NGOs, and public health agencies also worked. The WHO, the central node in the global viral network, had reports of rare late-season clusters of influenza-like illnesses in Mexico, what looked like a case of viral hemorrhagic fever in West Africa, and outbreaks of the Asian strain of Zika in South America. So then what happened? Why in all three cases did what began as a relatively small and localized outbreak turn into a large epidemic? The answer is that having access to data and circulating information widely is not the same as having knowledge. Intuitively, we know this. If I handed all of you a stack of information about a remote location, everything you needed, clinical case files, lab reports, statistical analyses, and then asked you to tell me what was going on, you'd probably be hard-pressed to do so, and you'd probably simply take a good guess. So what's missing? If you have all that data in front of you, why can't you tell me what's about to happen? The answer, unsurprisingly, is that you lack context and the particular expertise to see the forest for the trees. Knowledge requires prior experience of the type that is increasingly rare in public health because of the turnover rate caused by intense workloads and eventual burnout. The truth is that some people did know very early on in each case that something was happening and that a fast response was critical. Those were the people on the ground closest to the events. The global network didn't see this coming because they are drowning in a sea of data. Analysts that work in global surveillance are seeing reports from everywhere about everything. They are fielding hundreds of emails per day. In a crisis, that escalates to thousands of emails per day. In all of that digital flow of information, how is someone going to know which pieces not to ignore? The best analysts, like the ones I worked with, work in teams with different expertise. They have different specialties, so veterinary science, virology, parasitology, etc. And so they have access to more information and more knowledge with which to interpret information. They also typically have one or two senior people, folks who have been working in public health for decades and can add much needed context about a region or what a typical outbreak looks like. This context from those who are actually closest to the outbreak or those who have seen similar outbreaks or those who understand the region or the particular disease is critical to interpreting information accurately and producing what is called in the business actionable knowledge. And actionable knowledge is the life's blood of any public health response. The problem is that context is difficult to access. It doesn't circulate well in those digital flows. And in a situation where a few people are being asked to keep track of literally hundreds of daily automated surveillance reports, that's a real hamstring. It is something that greatly affected the earliest days of the H1N1 pandemic and has clearly not yet been solved. The events of 2009 did strengthen the already existent surveillance network and spurred renewed efforts to increase its reach and capacity. But as I was reading through the reports of events in 2014 and 2015 in order to prepare for today, I had the eerie feeling that I had seen all of this before. In many ways, the narrative is the same for flu, Ebola, and Zika, and indeed is being echoed now in relationship to this latest flu outbreak, H3N2. Early cases are picked up and analyzed and ignored just long enough for a small outbreak to turn into something bigger. We're bad at predicting because pathogens are great at surprises. They pop up in weird places and weird times and seem harmless. And we can't care about everything. Our resources are limited, and so global health makes choices about what to prioritize. Things that fit the profile get followed up on. We expect SARS in Hong Kong, but not in Nice. An odd case of Ebola here and there in Central Africa wasn't anything to worry about. And so it's interesting that it's in West Africa, a different location, but it doesn't trigger anything because it's still not seen as that unusual. We expect something like dengue to spread, but not to mutate into something that kills us in a week. We hope not. So what's the sum total of this, the surveillance evolution? The system does adapt. I think I messed up my slides here, but I'm going to ignore it. The system adapts, so every time it is surprised, it learns. But those adaptations aren't necessarily protective. They don't make us any more prepared for the next surprise. I hate to be the bearer of bad news, but without more resources and more surveillance capacity and more expertise, we won't see the next thing coming either. And because most people know this, the best plan is to be prepared for anything. So now we're going to move on and actually look at how we did in real time during the actual responses. So as far as coordination goes, in 2009, after the initial flu cases had been picked up by the surveillance system and patient samples had been shipped to Atlanta for testing and sequencing, the CDC knew the global community might have a real problem on its hands. Best case scenario, the novel virus was slightly more pathogenic and transmissible than other circulating flu strains. Phylogenetic trees were inconclusive about how bad the strain would be because, as every last evolutionary virologist working on gene sequencing will tell you, the biological past of a virus doesn't predict its future. It doesn't predict functionality in the future at all. What everyone knew was the virus was an admixture of 3 different gene segments, and its genetic roots were in the 1918 strain that had killed an estimated 40 million people. Biological information was flowing quickly and transparently through the system, but its usefulness was highly debatable for response. By all accounts, in the earliest days of the initial outbreaks, people were very wary to hit the panic button and turn on pandemic response. That being said, the history of the influenza virus and this particular virus's genetic relationship to the 1918 strain made a lot of people very, very nervous. By April 29th, 2009, less than 2 months after the initial cluster was discovered, the WHO declared a global pandemic. The global response system was activated, and health departments everywhere at the local, region, national, and international levels went into action. By 2009, every developed nation had some kind of a pandemic response plan. And I mean this very literally. Epidemiologists used to tell me jokingly that there were physical plans in place, a playbook, and that they were metaphorically being pulled off the shelves, sometimes literally being pulled off the shelves. And yet it was just like any other response. Alerts went out and cases of influenza-like illnesses were counted. Lab samples were taken from patients and shipped to centralized labs capable of sequencing and tracking virus mutations. The backlog of viral samples from 2009 is still legendary to this day. Trained staff were doing shift work in those labs 24/7 and still were nowhere near keeping up with the shipments flowing into their labs. The cases mounted, but it was unclear just from looking at the numbers what kind of response this new virus required. It turns out we're really bad at navigating official outbreak response plans during real-world events. The The plans prepped people and provided them with a map for response. Actions were clearly outlined and protocols for cooperation and information sharing were in place. In some ways, the response was very successful. When the switch was flipped, the global viral network produced a lot of information and a vaccine in record time. That being said, those pandemic plans also made it very difficult to go off the book. Once it was clear that the strain was not the threat that everyone had feared it would be, it was nearly impossible to stop the response actions that had been initiated by the WHO. Once the pandemic switch gets flipped, there is no off button. Case counting and clinical sampling continued long after anyone felt they were necessary. So resources were being expended on case counting long after anyone thought that was useful information. As for coordination, there were some serious problems. First, the WHO directs traffic, but it needs the cooperation of member states to function. The WHO doesn't have the staffing, resources, or permission to respond itself. National and international agencies like the CDC and the European Centers for Disease Control need to work together, not only to share critical information about transmission rates, genetic changes, and case counts, but to coordinate actions. In Veracruz, Mexico, where the CDC, Mexico's National Institute of Public Health, and the Pan American Health Organization had been sent for a coordinated response, things didn't go well. There were several problems, and I'll go over them separately because they will come back to haunt us when we talk about Ebola in just a minute. The Ebola's list is up, but it's going to be similar. One was duplication of tasks in the field. So as an example, the CDC and PAHO might both be focusing on contact tracing, while assuming the other teams were concentrating on getting viral samples and setting up labs. This seems to have been unintentionally related to the second problem, which was unarticulated priorities. So even though everyone had the same goal of stopping and slowing a growing epidemic, everyone had similar backgrounds and training. The different response teams had very different priorities. That's because they have different cultures. The assumption and mistake was that everyone had the same goals, which just wasn't true, and we'll see it remained an issue during Ebola. Understandably, Mexican health officials wanted to stop the spread and focus on treatment, but PAHO needed to case count for the WHO and coordinate between Mexico and the US teams. The US wanted to collect viral samples and contact trace. Political tactics got in the way of a coordinated response. As just a few examples, famously, China banned all flights from Mexico, which was poor epidemiology, but great politicking. Mexican officials decided to ship viral samples to the Public Health Agency of Canada and bypass the US CDC, which worked. And to this day, I still hear people complaining about the snub that they didn't get the first viral samples. Global health emerged during this response. It was the first test of the new system since SARS in 2003. And it was overall a successful test, the problems I recounted notwithstanding. But global health, as we think about it, doesn't really exist. The global health response to the H1N1 pandemic was really just loosely coordinated local and national responses. Like viruses and host cells, public health workers traded information and grew the response organically. But unlike viruses, which are famous for their ability to replicate at lightning speed, the viral network is limited by its low numbers of trained staff, experienced responders, and lab capacity. This is very apparent when we look at Ebola. So what went wrong in 2015 in West Africa, or 2014? The network that had worked fairly well in 2009 initially failed infamously, slowing response and worsening the outbreak. I'm going to go through this in rapid fire so we can discuss the implications and still cover Zika. One is part of the reason that the Ebola response was a mess is that different diseases have different histories and personalities. The history of Ebola, or what we thought we knew about this virus, negatively affected our response to it. No one thought that a few cases of Ebola would be this big of a problem, so no one acted initially. People close to the initial outbreak were acting, but the global network just ignored it and let the local people deal with it. The second major failing of the system is that when Médecins Sans Frontières, or Doctors Without Borders, sounded the initial alarm, the WHO thought they were overreacting. It would take 8 more months for the WHO to declare it an international emergency. 8 months. And the reason they thought that Doctors Without Borders were overreacting is that history of Ebola and the personality of Ebola within the global network. The third major failing is in international coordination once the network finally went into response mode. So MSF, or Doctors Without Borders, had been on the ground since the initial case and had been coordinating their own 3-country response operation. They were shunted aside when the US and UK military finally arrived in November of 2014. The priorities of the responders were all different, and the teams working in the field had no centralized coordination or division of tasks. The response was such a mess that many responders privately told me that they hold grudges against the WHO, in particular for their lack of leadership. The goals and objectives of the responders remained in tension with each other and probably slowed the response and harmed its overall effectiveness. The most contentious of these debates about protocols and response activities surrounded what we call CCCs, or community care centers. You can see a photo of one of those here. The WHO and the CDC wanted to spread out care, opening some of these centers around those 3 countries. MSF vehemently opposed the creation of these centers because of infection risks. They went up dramatically in these centers, and questions about the quality of care that would be received in these community centers. The WHO and CDC went forward despite MSF's strong opposition to this measure, and I can tell you that no doubt this will have long-ranging ramifications for good faith in future responses that require the coordination and cooperation of all those same actors. As far as lab capacity goes, they were, as I discussed earlier, they were hamstrung by access to accurate tests and staff with which to perform those tests, so diagnosis was often very delayed. The treatment facilities themselves were understaffed, famously, and under-equipped to handle the influx of patients. There simply weren't enough supplies or beds. This is an ongoing issue in every outbreak response. Supply and personnel are pernicious problems, and no matter how the viral network evolves, we can't seem to fix these logistical glitches. Lastly, the outbreak response plans were not easily scaled up. So there were response activities that were standard in Ebola response, but they were geared to smaller, more containable outbreaks. There were no guidelines for how to scale this response up quickly or expand treatment safely. This is a continuous problem of planning. It's hard to plan universally for what will be a specific set of circumstances. And then finally, the community outreach and culturally sensitive communications were in some cases non-existent and then too slow to get started. So qualitative data about the communities in which the responders were working was collected far too slowly. MSF had good connections. The US and the UK responders did not. Enrollment of local national health agencies in response activities was too slow or non-existent. Initially, the government of Sierra Leone denied MSF's aid, which clearly added gasoline to an already unhealthy fire. In some ways, it's very difficult to compare these 2 responses to Zika. We're talking about 2 very different viruses, different transmission methods, and very different effects. Obviously, Zika is not Ebola, is not flu. Zika will be a slow burn epidemic, and there's still much uncertainty about the virus itself, about the different pathways it takes, biologically speaking, how the virus leads to fetal abnormalities. There's still much that's unknown. That being said, I think there's some things about the ongoing situation, the global response, that bears discussion. As with flu and Ebola, the known history of the Zika virus had a large impact on our response. Reports of Zika outbreaks were well documented, but because the virus had a reputation as being a mild virus, you just get a fever, you don't feel well for a couple of days, no big. The initial response was matched to this outdated profile of the disease. There was a real watch and wait attitude toward Zika before 2015. The viral network of global and national health agencies didn't have a response plan in place for this type of event. There is no set plan of action for uncertain events, which of course makes sense. How can you plan appropriately for the unknown? The viral network does that by simply surveying and responding quickly to anything that looks like it might be problematic or likely to become an epidemic. We missed this one. It's that simple. And we didn't miss it because the information wasn't flowing. It was. As with H1N1 and Ebola, we caught the early murmurs. The problem is that the network isn't primed to adequately deal with things that don't fit into a well-trod mold. As always, the labs worked well, especially the US CDC. We developed rapid testing and got those kits out to local health institutions. That being said, the global community treated Brazil as a living laboratory, by which I mean we descended and we collected viral samples, and then we went back to our own labs and produced more information about the disease and its links to microcephaly, but we weren't really heeding Brazil and other nations' calls for help in terms of building an effective local response in South America. Politics also got in the way because the virus affects pregnant women, and the topic of abortions and pregnancy advice is infamously mishandled, continues to be. Personally, I think the national agencies were too mired in politics to respond quickly to this one. There was very little international coordination of response at all, despite the WHO declaring a public health emergency of international concern, or a PHIC. So in this instance, the viral response network never really came together. I would argue that it didn't really respond to Zika. Our poorly coordinated response to Zika underlies the fact that global health only functions as well as its parts. And if those parts aren't working well independently or together, things don't go well. Okay. So I'd like to end with 3 overarching observations of the viral network's evolution. First, the viral network of global health constantly mutates and adapts. It does so too slowly and only in response to current outbreaks. The network is not flexible enough. Unlike an actual virus, the superorganism of global health cannot adapt quickly and deftly. In part, that's because of their continued poor communication in between responses. During responses, communication is very good. When there's nothing going on, responses or communication doesn't really happen at all, or not as well. Political and economic constraints are always hamstringing the system, and bureaucracy obviously is a factor. Social networks work best in person, but we're living in a digital age, and the space of global health is too massive, obviously, to be conducive to a lot of face-to-face networking. That's why the actual responses help to build and rebuild the network, strengthening our global immune system. People actually see each other in the field and form trusting relationships that will then carry forward. That's overall a good thing, but this brings me to my second observation. System immunity isn't cross-protective. So path dependency is a serious constraint on the overall health of our superorganism. In public health circles, the joke is always that you're damned if you do and you're damned if you don't. Our knowledge of the history of flu caused an immune system overreaction to the novel H1N1 virus in 2009. The institutional history, or what we thought we knew about past Ebola outbreaks, led to an underreaction of the immune system to Ebola in West Africa. And the common knowledge and past experience with Zika virus led to a slower immune reaction to Zika in 2015. The shadows of past outbreaks and the lessons learned from those earlier responses carry forward in both good and not so good ways. Lastly, and relatedly, mutations in the global viral network are spurred by collective responses to epidemics, but they aren't always adaptive or effective. Like a real virus, the network evolves, but that doesn't always equate to progress. Very often it can feel to those working in public health that the system regresses after each response and then needs to relearn its lessons in each subsequent outbreak. Right now, we're in the midst of a surprise flu season with H3N2 creating more havoc than we anticipated. I'm not sure how or why this happened yet, except to say that real viruses do not play by our rules. They confound our expectations, and they require us to become more like them in order to effectively battle them. The global viral network needs to keep evolving, but clearly we need to start rethinking how we do that. And that's where I'll end. Thank you. Okay, should I field my own questions? 5 or so minutes. If anyone has
What we're going to do is ask those who have questions to come down to the microphone so we can pick it up on the live stream and the archive recording. Okay?
Nobody? Nothing? You have a question?
I have a question.
Okay.
Can you talk to us more about your time at the CDC and how our colleagues there welcomed you to observe and what you learned, and say a little bit more about what that experience was like?
Oh my God, it was incredible. So the Global Disease Detection Unit was fairly new when I was there in 2009. I think it had been created in 2005. And it was a team of 4 people who were responsible of keeping track of outbreaks everywhere. You can imagine they didn't sleep much. They answered emails at 5 a.m. They gave me access to everything. I went to every meeting with them. They gave me access to their email accounts, which I still can't believe that they did to this day. I sat in on all conference calls. I dialed into the international conference calls throughout the pandemic. And I tried to keep track of emails sent and received and went insane. So it was an incredible experience watching these people. And they all had prior experience and were all interconnected to their counterparts in other countries. So it was quite fascinating. And they're amazing. And you guys, even though I kind of just scared you, these people are on it, and I sleep well at night, unless I get a call from one of them that I shouldn't. Okay.
That was a really nice talk. Thank you very much.
Thank you.
So I wonder if you could speak a little bit about the sort of the broader context in which these labs are embedded. So for instance, there are academic projects like HealthMap, right? But also with Ebola in particular, the US sent the military, right? And so all the logistics and so forth are handled by the military, which is different for Ebola than Zika, for example. We didn't send the military to Brazil, right? So I wonder if you could talk a little bit about those kinds of things.
The lab network is so fascinating, and I actually think is a great model for cooperation. So a lot of these labs are at university level. The surveillance labs are sometimes at someplace like the Pasteur Institute, so they're independent or NGO level labs, and they're just constantly doing surveillance. They're constantly getting blood and saliva, fecal samples, and testing, seeing what novel strains are happening. During a response, other things get involved, other entities get involved. So you get military labs, you get makeshift laboratories in the field. The CDC is constantly working, but usually responding to, they do their own separate research, but then they respond when another lab picks up something and sends them an interesting sample. So they're constantly always communicating and talking. I have found that tends to coalesce along family lines. So for instance, they're the flu guys. We can talk about the gender of that at another point. But they refer to themselves as the flu guys. So they're the flu virologists. They have their own lab network. And so people who work on VHS or viral hemorrhagic diseases will have their own teams. So they're very much interactive with each other along viral family lines. And then there are labs that do everything that come online. So there are all these things that only exist when something happens. And when the military responded, like, it's not like that laboratory isn't always doing something, but its main function is to respond to these types of events. So it's really an interesting system, and they do talk to each other fairly well, I must say. That's one of the reasons you guys can sleep at night.
I have a question. As a publisher, I'm kind of interested in the sort of access to research and the arguments that you hear about open access publication and just the having ready access to the most current research. And what you were saying here about sort of information versus knowledge made me wonder about how important that aspect is, and if you have thoughts about the importance of access to research. Is that the issue, or is it more that, again, that issue of the question of context and that we have all that information, we just don't know what to do with it?
That's a great question. The scientists believe vehemently in transparency. The more political side does not. You can do your own math about why. But one of the interesting things is, and I should have said this in response to the interesting lab question first, I should say that different labs, if you're in the network, if you're a reputable lab, they trust you automatically. If you're not, they don't. So I'll give you an example. I won't use, I'm banned forever. The CDC nicely told me that if I ever accidentally say something I'm not supposed to say, that there's a nice federal prison waiting for me. So I will try to disguise this. During the 2009 pandemic, for instance, they got a report of an outbreak in a communist country that will not be named. And they didn't trust the information because they don't trust that lab because of the politics of that lab. So there are trustworthy and untrustworthy sources, and the trustworthy places produce trustworthy information. They are pro everything circulating, but the interesting thing is, even though information is transparent, it always needs to be re-vetted. That even if everything's flowing well, they'll get a report and then they'll pick up the phone to check on it. So access is important, but the thing that is most crucial is the context of that information. So that doesn't circulate, or it doesn't circulate well. That's the thing that people are emailing. They're outside of that main loop. So they are picking up the phone, or they were contacting, or they were texting people that they knew to get follow-up information on that quality lab data, if that makes sense. So there's constantly a need to make sure of the information. So open access is great. Transparent flow of information is great. But strangely enough, it doesn't solve the problem.
And this might actually be a rewording of the former question. So I work for NCBI, the Viral Genomes Group, and one of the things that we do is try to facilitate access to the genomic data that's available. We're doing a better job of adding metadata to it, so it's providing some context in terms of the country or the year, things like that. What other kinds of context do you think would be suitable that we could try to reach out for? And if this is something that I can ask afterwards, if that would be a better time, then I'm happy to stick around for.
Yeah, that's a tough one. Context, like, that's the interesting thing, is it tends to be around lab data. They want to know who produced it, because not only do labs have reputations, but individual people working in those labs. So if, I'll just use Hong Kong, there's a famous virologist, his name is Guan Yi. If he produces information, it's good. If someone else produces information, they have to check it, even if it comes out of the same lab. So who produces the information, whose lab it is, what kind of assays they use, where did they collect the samples sometimes, not just the genetic information, but where did that sample come from? Sometimes that's often coded already, but how it was collected, how it was processed, that kind of thing is crucial, because they have a tendency to mistrust people they do not know.
I'm afraid that due to time, we need to get back to the Viral Networks workshop. And I want to, in doing so, I want to thank Theresa for her fantastic talk and all of you here at NIH listening in and everyone remotely as well. Thank you, Dr. MacPhail, very much. Thank you.
Thank you.